Welcome to the Practice of Medicine podcast from the Southern Medical Association. Since 1906, SMA has had a singular mission to provide medical professionals with the resources they need to learn from each other and in doing so, improve the overall quality of patient care. The Practice of Medicine podcast is just one of the ways we do that, as we discuss a wide range of topics including multidisciplinary approaches to patient care and new innovations in medical technology. To learn more about SMA's many other services and educational initiatives, please visit us at sma.org.
Hello there, I'm Dr. Chris Morris. I'm currently president of the Southern Medical Association. And today I'm going to be speaking with Dr. Philip Hartman, who is presenting a lecture on alternative modes of and approaches to pain. This is a topic as a rheumatologist that is very, very important to me. We see a lot of patients with chronic pain. We deal with patients who have been referred to us with chronic pain. I think that my personal feeling is that, and I don't know how Dr. Hartman feels about this, but we have done a lot of damage to ourselves by emphasizing the idea that pain is the fifth vital sign. Because when you have a problem such as pain, that it almost implies you need to be treating it and you need to be doing something about that pain. And unfortunately, I think that's led to a lot of problems in our society today. Right now, we see patients who are regularly referred to us on lots and lots of opiates. And obviously, we need to find alternative modes to go at this. What are your thoughts? Is it correct for us to be immediately when someone comes in with a pain level of 2 out of 10 and they're trying to get that MIPS, is it correct to be using something like Lortab or Percocet?
Sure. So just to take one step back real quickly, I don't know that it'll necessarily be alternative management of pain unless alternative means alternative to opioids. So this is actually mainstream evidence-based pain management. And as you said, going straight to opioids, while it may be what some of us were taught initially, many of these things courtesy of editorials bandied around by certain pharmaceutical companies, drug representatives. But I know when I was in med school, our pain lecture actually included picking out an opioid, starting it and increasing it until the pain was gone or adverse events had occurred, at which point you would change drugs. It really does not make medical sense now. So part of it's retraining us, part of it's retraining patients. But as physicians, we don't like to get retrained. We would rather be re-educated. So what I've done for this is try to compile all the evidence-based research I could find that compared different modalities of pain management. And basically what we found is that while opioids do in fact at a high enough dose take care of most pain short term, there are many other things that have come up equivalent or sometimes even superior to them in pain management in blinded studies. So just as I could take a look at an infection and treat virtually any infection with vancomycin, metronidazole, aztreonam, and fosfomycin, those are probably not things I should be banting around at every infection that walks into my office. I would be much smarter to take a focused approach and to say, okay, what are the likely causes of this infection? Can I treat a cause? What are the symptoms I'm dealing with? Can I treat a symptom? And that's really what this lecture focuses on, is ways to take a type of pain that comes in to see you and treat it in a more specific and less harmful way that is also supported by evidence.
One thing that's interesting in my thoughts about pain is that we all know that using the opioids has become basically a one-size-fits-all approach. We see patients who come in with a lot of pain, and we don't begin to even consider what kind of pain it is. I remember seeing a patient who was diagnosed with fibromyalgia and came in and was walking in and literally on 240 milligrams a day of morphine, and they could not understand why they were hurting because of all the pain medicine they were on. And how do we go across? How do we go about just thinking about patients, trying to come up with maybe the kind of pain and maybe tailor the approach on the pain management to their kind of pain?
Sure. I think we do it the same way we do everything else we diagnose. If we start treating pain like we treat other things we diagnose, you come in and you say, gosh, I'm urinating a lot. I don't say, okay, urinating a lot. It's automatically, no, it could be diabetes. It could be a urinary tract infection. It could be an overactive bladder. It could be incomplete emptying. It could be a neurologic defect. So there are so many things it could be. It could be a bladder irritant. You could be drinking Red Bull and vodka, and that will make you urinate a lot for sure. So by tailoring our care the way we want our own care tailored, I don't want to walk into a doctor's office and have him already know what he's going to hand me before I've even told him what's going on. So by treating our patients that same way and saying, is this a musculoskeletal pain? Is this a specific type of headache syndrome? Is this chronic pain or acute pain? That's a great place to start, to look at it differently based on the source of the pain to figure out if we need a pharmacologic or non-pharmacologic modality. And then knowing that there are things that are shown to help with headache pain that have been shown not to be relevant to the treatment of chronic low back pain. Well, that's important. If we have something that on a studied scale has not been effective for a type of pain, well, that tells me it's very important that we pay attention to the type of pain we're treating.
Well, one interesting thought, and this is something that also is I've seen more than once. Patients that'll come in and they say they've had their primary care person increase their pain medicines and discover that it's even gotten worse. How often do you think we are overlooking an opiate-induced hyperalgesia?
A significant portion of the time. I think if you look at the data on chronic use of opioids compared to a no treatment model, patients are in more pain on chronic opioids than they are if they are not treated at all. And then having switched patients to more appropriate things for their pain, I always tell them there's going to be a period during which you're not very happy with. We obviously want to take them down appropriately. You don't just want to cut somebody off who's at a 240 milligram morphine equivalent per day dose to nothing instantly. But if you can appropriately taper them off, and if you can appropriately treat the symptoms of withdrawal, I have frequently found in my own office that part of what was being treated was withdrawal from opioids. That the pain they were initially treated for was not what they were actually taking this based on symptoms of. And then on top of that, as you said, pain fibers are meant to feel. The difference between feeling pain and not feeling pain is dramatic. The children who are born with sodium receptor defects that make them unable to feel pain chew off their own fingertips as they teeth, because it's just this great sensation of chewing on something of a great texture with no pain. So I tell patients the difference between being able to feel pain and not is the difference between, hey, look at this cool alligator, and hey, get this off my leg. And that's very Florida pertinent for our upcoming meeting. But that's what I'm looking at is we have to realize that pain is necessary for life. Now, chronic pain is a different beast. Chronic pain means that there's no noxious stimuli that needs removed. You're not sitting there with your hand on a hot burner. There are nerves that are firing inappropriately in a way that's not beneficial to prolonging your life. But at the same time, those drugs are not specific to chronic pain receptors in any way, shape, or form. And the body does use opioid receptors for lots of things that we frankly know very little about. Acupuncture. At our last SMA conference, those who were there heard that acupuncture is less effective in patients on chronic opioids. So when we block these receptors, we stop the body's ability to do what it needs to do, both to provide us comfort and to keep us safe. So obviously the body's going to revolt against this, much as someone who uses Afrin on a regular basis will constantly have nasal congestion in between doses of Afrin. That bogginess of the nasal mucosa is a much easier to see version of the increased nociception and opioid-induced hyperalgesia syndromes that have led to dose increases in many patients.
An interesting conversation I had with some of my rheumatologic colleagues. We were talking about meaningful use modalities and how there is a measurement of pain. And if a patient has a pain that does not have a pain level of zero, it's, what are you doing to fix their pain? And the thing that came up with all of us is that we have patients with rheumatoid arthritis and with other inflammatory arthritic diseases that have a pain level of 3 or 4, and that's their baseline, and they feel fine. How do we address the fact that there are some times when we don't need to be treating pain and getting it to zero?
So the studies that you'll hear me quote when I give the talk on evidence-based treatment of pain had to use quantitative pain scales because it's incredibly difficult to hit statistical significance if you don't quantify something. Now, in clinical practice, I do not use quantitative scales, I use qualitative scales. So if I'm not yet treating pain, I ask the patient, is it mild, moderate, or severe? And if I'm already treating pain, I ask the patient, is it adequately controlled or inadequately controlled? Because like you said, if if with my back being bad, a good day for me is 3 to 4 out of 10 pain, I don't take something when I'm on 3 to 4 out of 10 pain. And then the other thing I'll do, because patients have gotten trapped into this concept of I should have zero pain, not all, but some, is I'll try to focus more on function than pain scores. So patient says my pain is inadequately controlled. One of the questions I frequently ask is, what is it that you would like to be doing or should be doing that your pain is prohibiting you from doing? And in that way, we can make goals for our treatment that are oriented in something more feasible than a zero pain score, because a patient with bad rheumatoid arthritis is not going to have a zero pain score and still be functional. We could put them under general anesthesia. Fine. They have a zero pain score and they can do nothing. So I try and fix that conundrum by focusing and trying to redirect focus towards setting goals that are realistic and obtainable. So, what can you not do that you feel like you could do if your pain was better? And if they say, I try to take my grandkids to the park, and after 10 minutes of standing there, I have to go find a seat because this is how bad my low back or my knees hurt. I can work with that. I can say, okay, so a functional goal would be, how long do you think is a good amount of time to be there? And they might say, gosh, if I could just stand for 30 minutes, I would be good. Perfect. Now we have a reasonable goal that we can reasonably work toward without trying to pretend like we're going to get them to a zero pain score.
Okay, I have one thought of my mind, and this is, I guess, goes in the everything you know is wrong category of discussion. A week ago, was going through my regular reading and noted that there was an article in which the surgeons in this one group discovered that nonsteroidal anti-inflammatory drugs did actually better than opiates for post-operative pain. Now, of course, every surgeon I know cringes when they hear the word NSAID because of the fact they're sure their patients are going to bleed out. How do we go back and reassess things and maybe go back and say, you know what, maybe we weren't so, maybe this information wasn't on the back of the tablets that Moses brought back down from Mount Sinai? Because, I mean, and rethink about what we've always known before.
Sure. I think the first place to go is to take a step back further and realize that providing all post-operative patients with opioids is, in some cases, a fairly uniquely American approach and is a fairly new approach in medicine. This isn't something that was always done. I mean, if you've ever read the book, The Butchering Art, that looks at early surgery, which if you haven't read it, it's totally worth reading. They talk about how the very best surgeon prior to anesthesia was the one who could most quickly remove a limb. And it was some number of seconds that was the record for removing an entire leg. But in all fairness, when the gentleman who removed that leg did so, he also accidentally amputated the arm of his assistant. So I think one is looking back and realizing,
A leg then.
exactly, it surely did. And to look and see that, one, people didn't always receive opioids after surgery. And two, understanding only the side effects of those things that you do not use is not safer than understanding the repercussions of those that you do use. As a primary care doctor, I know you say they're saying, oh, they're going to bleed out. They're going to bleed out if we give them non-steroidal anti-inflammatories. I'm the one sitting here going, oh, you're going to kill my patient's kidneys. I've got her on 40 milligrams of lisinopril and you just put her on maximum doses of meloxicam. Thanks a lot. But looking at how to balance those and looking at some of the evidence as far as dosing goes, there have been some good studies recently that looked at lower dose versus higher dose anti-inflammatories and found that you do not have to hit anti-inflammatory dose levels to hit analgesic dose levels. So again, we don't know why some of these things work. This shouldn't be a surprise to us in medicine. I know it's a big surprise to our patients when they hear, oh, we don't know why Tylenol reduces fevers. But I think those of us who've been doing this even for just a little while realize that not everything we know is correct. And even when we know the mechanism, we often have later research come out that says, well, okay, but you don't even have to hit that concentration. You're not even really blocking that cyclooxygenase and fighting the war against phosphodiesterase. You're not even doing that when you do this, but it still works.
All right, one last topic I think is going to be a hot one, and it is one because every week I have a patient come in that asks me about. And there has been such a flood of the cannabinoid-based products out there. I don't want to call them medications. I want to call them cannabinoid-based products.
The
And
FDA agrees with you.
when someone asks me about using one of the CBD oils and everything else, I ask them, I liken it personally to having somebody come in and say, I've got a headache. Let me go get some willow bark and chew on it so that I can get the aspirin out of it. And I think that what is the strong data in every direction? Because data I've seen from Europe, where they are using cannabinoids much more regularly, they show that there's some benefit, but they also show that they are not the panacea that everyone here likes to publish them in.
Sure. So I actually have an AAFP article pulled up in front of me that was a review of various things for treatment. Now, one thing I'll tell you is there is limited evidence, and there's limited evidence for a few big reasons. So if you're talking full spectrum, as in contains THC, if you're talking the full spectrum that includes THC, when a drug is a Schedule 1 controlled substance on a federal level, you're not going to get many good studies because the hoops you have to jump through to get a good study are high. And then also clinicians tend to be risk adverse. And when you say, hey, this is a Schedule 1 controlled substance that you've only ever heard of recreationally, fewer researchers are interested in delving into that. Now, for the CBD oils, as you said, we shouldn't call them medicine because they're not regulated as such. They're regulated as foods. So when patients say to you, well, I don't want to take that medication, I don't want to take that meloxicam because I opened up the insert that was in it. And did you see how many side effects are listed? Well, let's be honest. If the side effects of a Big Mac extra value meal were listed when a person purchased it, they probably wouldn't. If we look at our food products that are sold to us, they're not required to tell you those things. They're not required to study them. In fact, they are required to put a disclaimer on the side that says this is not shown to treat, not intended to treat or prevent any ailment. So the quality can vary. I know that when I talk to patients about trying a CBD product, because I don't think that just saying, oh, well, there's not good evidence, I'm not going to talk to you about it at all, is necessarily appropriate. We can still guide towards safety. So I remind them that there's absolutely nothing that's ever been inhaled into the lungs other than room air that has not proven dangerous to the lungs. So I obviously don't want my patients smoking anything or vaping anything. As far as CBD oils go, they're typically either in a candy form or a liquid oil form, and they have very poor digestive absorption. So usually they're absorbed through the buccal mucosa. They exist in full spectrum oils that can contain THC, in purified oils that still can contain a tiny bit, and full spectrum you can only get in certain states. And then the more limited spectrum, and then there's the distillates. The distillates are the ones that theoretically, if they're done correctly, and if you get the laboratory analysis, should contain no THC, which is important for anybody whose job could potentially lead them to a substance of abuse screening. I know that I would not trust my medical license to a supplement that hasn't been proven to work on something. But cannabis in general. So let's go back to that. It was brought up in the AAFP article to look at its uses for short-term quality of life, intermediate-term function, intermediate and short-term pain relief. In some of those categories, there's no evidence at all. Now, in other categories, if you were to look at the article I have in front of me, it says weak evidence. So they gave it 1 out of the 3 potential dots they had, but it's weak evidence that it provided no benefit. So for short-term quality of life, short-term function, and short-term pain relief, the weak evidence that exists all showed no benefit. So from that perspective, do I think more research needs to be done? Sure. I would be happy to see more research done. As it stands now, can I recommend CBD oil or cannabinoids to my patients for pain relief? I cannot. Now, CBD oil has showed some promising effects, potentially as an anxiolytic. But again, if I'm going to recommend it, I'm going to let them know that it's not strong evidence and that there's a huge variety of products. They're not incredibly well regulated. So you want to find something that has independent laboratory testing analysis to show you what you're actually buying. And then we look at things like published safe limits, because if the studies at least showed that it's not dangerous below a certain number of grams per day, I tend to lean them toward staying below that level.
That sounds a lot like what I think about with them. I tell patients I'm not going to say don't take them, but I say to them before I recommend something, somebody to prove to me that's going to help somebody other than the pocket of the guy selling it. And that's where I think the biggest thing we stand right now with a lot of these. It's sort of interesting. I've listened to advocates for use of cannabinoids who talk about how safe it is and how unimpressive it is, yet they don't seem to look at some of the data that's come out of Europe and where they are doing some full-blown studies because they don't have the limitations we have. The data out of Sweden that showed that adolescents who smoke marijuana have a 6-fold increased risk of schizophrenia. And I mean, this is something that bothers me quite a bit when I hear people say, "Oh, it's just as safe as alcohol or something like that." But I do think this is good. I agree. I think we need more data on this. I think doing more research on these products. And if there is something in these CBD oils, why don't they isolate it, find out what that one product is, and then use that? Because that makes a lot more sense to me.
Yep. And I'm sort of a purist in that mode too. I think that less chemicals into me is better than more chemicals into me. So if there's something that's effective, I'd rather have the something by itself.
Well, I think I'm looking very forward to hearing your lecture at the meeting. And I appreciate the chance to chat with you about this. And both Dr. Hartman and I are happy to answer any questions. If anybody has them, feel free to contact us through the SMA. And thank you for your time today.
Absolutely. Thank you for yours. It was great talking to you.
See you in Orlando.
We hope you enjoyed the practice of medicine. For more episodes in this series or SMA's The Business of Medicine podcast, go to sma.org/podcast or subscribe to us on iTunes, Google Play, Spotify, or wherever you get your podcasts. For more information about SMA's mission, please visit sma.org, and thank you for joining us today.